Hello, everyone. Thank you for joining today's webinar, where we will be discussing how Tennessee can leverage doulas to improve maternal and infant health outcomes. If you have any questions throughout this presentation, please place them in the Q&A box and I will answer them at the end. All right, well, my name is Asia Porter. I will be your presenter today. I am the King Child Health Fellow here at TJC. So I work directly with families to get mothers and children health services. I also work on our children and maternal health policy goals, which we will focus on in today's conversation. Before we begin, I do want to raise your attention to a couple of our upcoming events. Next Thursday is the start of Black Maternal Health Week. And so in celebration, we'll be collaborating with partner organizations to bring you the following events. First up, on Friday, April 12th, we will be hosting a roundtable discussion about doulas, where we will continue the discussion that we are starting today about how we can expand access to doula services in Tennessee, specifically through Medicaid. We have some great panelists lined up for you, all of whom have experience working as community-based doulas. And that event will be from 12 p.m. until 2 p.m. and lunch will be provided. Then on Wednesday, April 17th, we will welcome Dr. Karen A. Scott, who is the founding CEO of Birthing Cultural Rigor, and through her work aims to address obstetric racism. She will be speaking in a webinar about patient safety in birthing hospitals. There will be great information and insights shared at both of these events, so we hope that you can join us. If you are interested in attending, registration links will be sent to you in a follow-up email after this training. Without further ado, let's get started. So first, I'm going to cover what a doula is and the benefits of a doula-supported birth. Next, I will provide some context for the state of maternal health, both nationally and in Tennessee. Doing so will require us to examine racial disparities in maternal health care and underscore why access to doula services is largely a health equity issue. After that, I will discuss current policy efforts in our state to enact Medicaid coverage of doula services. For those of you who are not aware, Tennessee's Medicaid agency is called TennCare, so you'll hear me refer to TennCare throughout the presentation. Finally, I hope that you all will be interested in continuing this conversation, so I will share how you can get involved with our advocacy efforts. So first up, what is a doula? A doula is a non-clinical professional who provides continuous physical, emotional, and informational support to childbearing people before, during, and after childbirth. A common misconception is that doulas replace doctors, but this is not the case. Doulas do not replace licensed medical staff. Rather, they work alongside doctors, nurses, and midwives to ensure the patient is adequately cared for, supported, and that their concerns are being considered. There are many ways in which doulas support their patients through the pregnancy, childbirth, and postpartum periods, including but not limited to creating a birth plan, teaching breath work exercises, providing breastfeeding support, acting as a mediator between patient and clinicians, and many more. Some of those benefits include reducing low birth weights and preterm births and labor, reducing C-sections, reducing anxiety and depression during pregnancy, reducing birth complications, and increasing breastfeeding. Mothers who are supported by doulas generally report an overall more positive birth experience than mothers whose births were not supported by doulas. And there are also considerable cost savings benefits to doula-supported births, but I will discuss that more later in the presentation. One thing that I do want to mention is that while doulas were not formally introduced into the United States healthcare system until the 1960s, they have been around for centuries. The word doula is derived from ancient Greek, and it means a woman who serves. And for centuries across all cultures, doulas have been pivotal and critical to pregnancy and postpartum care. But in the United States, doulas are largely unsupported by our formal healthcare system, which is a problem that we hope to address. So despite all of those benefits that I mentioned, we see fairly low utilization of doulas in the United States. In 2014, the National Institutes of Health, or the NIH, examined utilization of doula services. They collected survey data of publicly insured, privately insured, and uninsured pregnant women across the United States and assessed their awareness of doulas. In doing so, they found that 59% of women knew what a doula was and its benefits. And of those women who said that they were familiar with doulas, 27% desired to have a doula-supported pregnancy and delivery. But only 6% of those who wanted a doula were actually able to access a doula for their pregnancy. And so the question is, why? Why is this number so low? A big reason is what I mentioned earlier. Doulas play a critical role in pregnancy and childbirth, but they're largely unsupported by the American healthcare system. The cost of a doula can range anywhere from $700 to $5,000, depending on where you live and what services you're looking for them to provide. And so many families cannot afford to pay for a doula out of pocket on top of all the other expenses that come with having a baby. This really underscores the importance of expanding access to doula care because we do not believe that income should be a barrier to quality maternal health care. Expanded access to doula care is particularly salient to moms in the United States because we are currently experiencing a maternal health crisis as declared by the US Department of Health and Human Services. Now, previously, entities such as the World Health Organization reported that the United States maternal mortality rate was 10 times higher than that of other industrialized nations. But emerging research as early as 3 or 4 weeks ago is now suggesting that that data may have been a little bit misleading due to errors in the way that hospitals collect data about pregnancy-associated deaths. So now researchers believe that our maternal mortality rate may not be as high as we once thought it was. Still, even with this new data, the US is still behind several industrialized nations, and this new data also does not show any decrease in racial disparities within the United States. So pregnancy-associated deaths and maternal mortality more generally is still a very relevant topic of conversation. But before we dive too deep into the state of maternal health in Tennessee, I want to pause to briefly define some of the terms that you may hear me refer to. So in discussing mortality within the realm of maternal health care, there are three possibilities. The first is pregnancy-associated mortality, then there's pregnancy-related mortality, and then lastly, and the one that we talk about probably the most, is maternal mortality. So maternal mortality refers to death during pregnancy and up to 42 days postpartum that is clearly linked or related to pregnancy. Pregnancy-related mortalities or deaths that occur during pregnancy and up to 1 year postpartum that again are related to pregnancy. But lastly, we have that pregnancy-associated category, and pregnancy-associated deaths are those that happen during pregnancy and up to 1 year postpartum, but there is not a clear link to the death and the pregnancy. So for example, if a pregnant woman got into just a random car crash one day and her death was attributed to the impact of the crash, that would be classified as pregnancy-associated mortality rather than maternal mortality. So looking at Tennessee specifically, March of Dimes, and March of Dimes is a great resource. They look very closely at maternal health, infant health, all of that great stuff, and they really advocate for the improvement of maternal health across the United States. So they release an annual report card, they release state-specific report cards, and they also release a national report card. So looking at Tennessee, Tennessee received a D this year. I believe that last year we got an F, so there is slow progress being made. But Tennessee consistently has a higher preterm rate than the national average. Preterm birth is defined as a birth prior to 37 weeks of gestation. So ideally, full gestation is 40 weeks, but anything after 37 weeks is considered full term. So like I said, Tennessee does consistently rank higher than the national average when it comes to preterm birth. And on your screen on the right-hand side are some possible leading factors as to why. They're listed in no particular order, but for example, smoking, and this could be smoking prior to pregnancy or during pregnancy, that's present in about 9% of Tennessee births. And of those pregnancies where smoking is present, 15% of those end up being preterm. So when we examine maternal mortality and maternal health, it's really important that we understand not just what the disparities are, what the statistics are, but really why these outcomes are happening, because that allows us to identify opportunities for reform. So Surgo Health created what's called a maternal vulnerability index, and this index examines a person's risk for poor maternal health outcomes within their unique social, clinical, and environmental context. And so as a result, we not only see specific counties where maternal vulnerability is higher, but more importantly, we can understand why it's higher. When you look at Tennessee, you'll notice that virtually every county, with the exception of Williamson County, which is that light spot in the middle of the state, you'll notice that they all have a maternal vulnerability index score of 40 or higher. This is not good. The max score is 100, and the higher your maternal vulnerability index score, the greater risk you have should you become pregnant. So again, the maternal vulnerability index not only tells us the risks, but it also tells us the why behind the risks. So in Tennessee, mental health and substance abuse is a huge driver of poor maternal health outcomes, followed by physical health and then general health care. This underscores the importance of a coordination of social, economic, environmental, and clinical interventions. A big point of contention that doulas often will say is that, people feel that doulas are the solution to everything, that, oh, if we just slap a doula on it, then the problem will be solved. But that's not the case. Doulas are a great starting point, but they're not the end all be all. They do address mental health. As I said earlier, one of the benefits to having a doula supported birth is that it does reduce the prevalence of depression and anxiety during your pregnancy and also postpartum. So it does chip away at that underlying cause. However, it's not the ultimate solution. There need to be other policies in place to address substance abuse in Tennessee, poor physical health, general health care, physical environment, et cetera, et cetera. A large policy that we champion and that research indicates would be a positive policy goal is Medicaid expansion. And so that would get at improving general health care, for example. Earlier, I said that maternal health care and access to doula care is largely a health equity issue. That is because Native women in the United States are twice as likely to die during childbirth as white women, and Black women are 3 times as likely as white women to die during childbirth. So I've included pictures. You might recognize some of these faces, but on the top left is a picture of Charles Johnson and his wife, Kira Johnson. So Kira died shortly after giving birth to her and Charles' second son. She went in for a routine C-section or a planned C-section, and shortly after giving birth to her child, Charles noticed blood in Kira's catheter. He alerted clinicians, nurses, doctors to the fact that there was blood in his wife's catheter, but there wasn't much urgency to address that situation. Doctors even ordered a CT scan stat, but that never really happened. It wasn't until 10 hours after Charles reported seeing blood in his wife's catheter that doctors actually took Kira into surgery. By the time that they took her into surgery, they opened up her abdomen and saw that she had hemorrhaged 3 liters of blood and she died on the operating table. And so her story is just one story of many of how Black women's concerns are dismissed when they're pregnant or giving birth. Serena Williams and Allison Felix similarly made headlines when they opened up about the struggles that they had during their pregnancy and delivery. And a large response that they got was, how is this happening to Serena Williams? How is this happening to Allison Felix? They're in great health, they're celebrities, they're wealthy, they presumably have access to a great medical team. But when it comes to Black women, mitigating factors, so those factors such as educational attainment, wealth, things like that, those factors that we typically see helping to improve health outcomes, when it comes to Black women and maternal health, they actually don't make a difference. A Black woman with a college degree is still more likely to die during childbirth compared to a white woman without a high school diploma. And she's still about twice as likely to die compared to a white woman without a high school diploma. So those mitigating factors really don't go that far for Black women when it comes to maternal health care, which is why this topic is so important. The NIH actually did a study into providers' ability to recognize pain in their Black patients, and they found that providers are less quick to recognize pain or discomfort in Black patients compared to how quickly they can recognize it in white patients. That same study found that providers are more likely to assume or perceive that Black patients are of a lower socioeconomic status than their white patients. And that study found that providers are less likely to feel warmly towards their Black patients as they are their white patients. So this really is consistent with a lot of Black women and a lot of women of color's reports of feeling dismissed by providers during their pregnancy and during their childbirth. In Tennessee specifically, the Tennessee Department of Health found that discrimination contributed to 1 in 3 pregnancy-related deaths. This graph displays the ratio of Black and white maternal mortality. So you'll notice that racial disparities between Black and white women within maternal health care have largely gone unchanged. We are essentially in the same position today as we were in 1947. I believe that the ratio today is 3.06, so a Black woman is 3.06 times more likely to die during childbirth than a white woman. In 1947, it was 3.08. So we haven't made too much progress. So I just want to pause really quickly and say that all of those things considered, the reason why doulas, specifically community-based doulas, are such a leading intervention and why people are so enthusiastic about doulas is that they can help to alleviate those issues of women's concerns not being considered or addressed by providers. Because again, going back to the function of a doula, doulas can act kind of as that mediator between their patient and the clinician. So how do we expand access? That's the big question. Across the nation as a whole, 40% of births are paid for by Medicaid, and this is slightly higher in Tennessee. 44% of births in Tennessee are covered by Medicaid or TennCare. And so advocates across the country have identified Medicaid as a potential avenue for advocacy to expand access to doula care. And actually, I'm going to go back to this slide really quickly. You'll see the stars. There are, I believe, 26 states who are either currently actively providing coverage for doula services or in the process of implementation. The way that states have gone about this can range anywhere from a governor's budget to legislation in the legislature, etc. But we'll go more into how we think that Tennessee can best implement this in later slides. So advocates in Tennessee, just like all the other states in the country, have been working on this for quite some time now. Senator Lennon Lamar from Memphis has been a great advocate in this way. So in 2022, Senator Lamar introduced a bill that, as introduced, would have enacted TennCare coverage of doula services. It was not passed as introduced. It was instead modified to simply require the Department of Health to collaborate with TennCare to study existing state certification programs. This was a big point of frustration for some advocates because many people feel that those benefits are already well studied. But nonetheless, that was a point of progress that we made in 2022. In 2023, Senator Lamar again introduced a bill that would result in TennCare coverage of doula services. And again, that was stifled and it was modified to instead create a 5-member doula advisory committee. So this 5-member committee is comprised of a representative from the Department of Health, a representative from TennCare, and 3 practicing doulas, 2 of which must be community-based doulas. And so the role of this committee currently meets monthly, and the role of this committee is to establish core competencies that a doula must demonstrate in order to be reimbursed by TennCare. And then to be reimbursed by TennCare, they also have to recommend a fee reimbursement schedule. So they have to recommend how much the state is going to pay a doula to provide services to Medicaid beneficiaries. And that is a whole nother issue within itself, and we will go into that further in a couple of slides. This year, there's currently a bill that, again, as introduced, would add doula care as a service that is covered by TennCare. This bill requires the Department of Health to establish a process of how they would go about certifying doulas. So in this next slide, you'll see the bill text of Senate Bill 1739. So this is the one that was introduced this year. And you'll see that it outlines 5 core competencies. A doula must demonstrate understanding of basic anatomy and physiology as it relates to pregnancy. They must have the capacity to employ different strategies to support someone emotionally, educationally during their pregnancy and delivery. They must have knowledge of and the ability to assist families with utilizing non-clinical labor coping mechanisms. So these were the things like the breath work exercises that we talked about. They must have an awareness of strategies to foster effective communication between clients, their families, support services, and healthcare providers. Again, doulas acting kind of as that middleman between the patient and the clinician. And then lastly, they must have knowledge of community-based, publicly and federal funded clinical resources available to the client for outside need. So this could be being able to connect them to things such as WIC or SNAP or other programs outside of their purview as a doula, but that would be beneficial to a person who is going through pregnancy or has a newborn baby. Now, the process of actually verifying whether or not a doula can do these things is going to be up to the Department of Health, at least as the bill currently outlines. Now, there are discussions as to how the state, or rather how the Department of Health would go about certifying doulas. One proposal, and this is actually, we feel that this is a flawed proposal, but one proposal is there are a few national and international doula organizations that train doulas. They put them through a multi-week long program so that they are capable of providing care to a patient. Well, one proposal was to pick out these large national and international doula organizations. And if a person has gone through training and has a certificate proving that they've gone through training from one of these programs, that they would automatically be certified. The apprehension with that certification process is that a lot of these national and international organizations are white owned and led. And with doulas, again, this is a health equity issue. A big driver to increase access to doulas is because of the benefits that it would give to low income pregnant people of color. And so that the concern is that that certification process would set up unnecessary hurdles for people who went through community-based training programs, for people who didn't go to those large national and international training programs that are largely white-owned. Instead, we advocate for the Department of Health to set up a certification process that is consistent for every doula, whether you went to a community-based training program or you went to a national or international training program. Fiscal incentives. So a big concern for many legislatures is the cost of implementing TennCare coverage of doula services. There is quite a hefty fiscal note currently attached to this bill, which is one of the reasons why we and other advocates are skeptical that it will get past this session, is because of the fiscal note that's attached to it. However, doula care overall does lessen healthcare spending, and this is supported very heavily through research. Doulas, as I mentioned earlier, reduce the rate of C-sections, reduce preterm births, reduce the use of epidurals, and reduce associated medical complications and chronic conditions. All of these things are extremely costly to the healthcare system. And so by investing in doula care up front, Tennessee has the opportunity to save money down the line because of the fewer complications that we will see in childbirth. Doulas also help to increase the rates of breastfeeding and spontaneous vaginal births, which similarly do result in healthcare savings. So looking at preterm births and C-sections specifically, because that is probably where the most research has been done into how much money can be saved through this policy. Preterm births, so again, these are births that happen prior to 37 weeks of gestation. Preterm births cost about 3.7 times more than a full-term birth. And doulas, research has shown that doulas could reduce preterm births by 25%. So in 25% of births, assuming that if this bill is passed, moms actually do go ahead and hire a doula, and 25% of those births, the state could be spending almost a fourth of what it's currently spending. Next, with C-sections, doulas can reduce C-sections up to by 40%, and this is very heavily supported by research. In Tennessee, this would result in about $17.8 million in annual savings, with the potential of there being even more, depending on, again, that utilization rate, depending on how many moms end up hiring a doula for their pregnancy. So what are some policy challenges? So the first takeaway and the first challenge is that doulas should not be evaluated as midwives. In states that have previously implemented Medicaid coverage of doula services, there has been a tendency to want to treat doulas the same as midwives and set up a reimbursement schedule that is similar to the reimbursement schedule for midwives and for doctors. This is very flawed, though, because of the differences between the support that doulas provide and the support that clinicians provide. Both are extremely important. However, they are different. Doulas provide continuous support. So from the time that you're pregnant and through your postpartum period, they are constantly they're constantly serving their patient. They're often on call for multiple months at a time, 24/7. And so as a result, they're extremely limited in the number of patients that they can serve in 1 month. Doulas might have 1 to 3 patients in a month. Clinicians, on the other hand, have dozens of patients at a time. And so if you're reimbursing a clinician $800 per patient, that could be $8,000 plus a month. But for a doula, that might only be $800 a month, which is not a living wage. The second thing is that if the state were to implement a low reimbursement rate, we've actually seen that this can stifle progress. So this happened in Oregon. Oregon was one of the first states to enact Medicaid coverage of doula services back in 2014. And so people were really excited about it, but the state only put forward a $75 reimbursement rate. If you remember from the earlier slides, a doula can cost out of pocket anywhere from $700 to $5,000. So a $75 reimbursement rate is extremely low. And what they ended up seeing was that less than 2% of births were supported by doulas. Doulas did not want to serve Medicaid beneficiaries because they knew that they weren't going to be paid a living wage for doing so. So we recommend that the reimbursement rate is $1,100 or higher. That is not currently what is in the fiscal note. So again, another policy challenge with getting that implemented. And then third, doulas alone are not enough. I talked about this when discussing the maternal vulnerability index earlier. There are several reasons why we have the maternal health crisis that we do. And it's not just provider actions. It's not just medical curriculum. It's mental health, it's substance abuse, it's the physical environment, it's general health care. And so one intervention, even if it's doulas, even if it's something that research is showing to be a very strong intervention, one intervention alone is not going to be enough. So there do need to be additional socioeconomic supports. Again, here at TJC, we really champion Medicaid expansion, but another emerging, or not even emerging, but another very heavily supported policy intervention is paid family leave. So again, how can you get involved? Again, we have these events coming up. Now that I've provided a little bit more context as to our policy goals, I want to speak a little bit more about that first event. So with this roundtable, I mentioned that states have gone a variety of routes. They've attempted to go through the legislature, they've attempted to go through governors' budgets. And so that's what we're really going to discuss at that event, is how we can effectively push this proposal, hopefully, to the governor. And so we are going to be discussing some of those pitfalls and policy challenges that I discussed earlier. And we're hoping to really have a big discussion between community birth workers, clinicians, or just anybody in the community who's interested in this topic. We're hoping to get you all involved so that we can draft a proposal to the governor. So if that's something that you're interested in, definitely register for the event next Friday. And then again, Dr. Scott will be speaking that following Wednesday about addressing obstetric racism in U.S. hospitals. All right, so now I'm going to turn to the chat. I see that we have a couple things. Yes, this is recorded and it will be emailed out afterwards. You will receive the slides, you'll receive a recording of the training, and you will also receive registration links for those events coming up in the next 2 weeks. All right, if there are any other questions, feel free to drop them in the chat. I'm going to stay on for about 15 more minutes. Otherwise, thank you so much for joining, and I hope to see you at our events in the coming weeks. So somebody asked, are there doula resources for moms with limited to no income? Currently, no. That is another goal with expanding access to doula care. So some states have went about offering reimbursement through private insurance. Here at TJC, we're currently trying to get reimbursement through Medicaid, so public insurance. But there are various avenues for how we can expand access to doula services. This training and our organization is primarily focused on expanding access through public insurance. Someone asked about Homeland Heart Doula Services. So yes, Homeland Heart is a doula collective here in Nashville, Tennessee, and it is a community-based doula collective. It is Black founded, Black led. Kristen, the founder of Homeland Heart, is amazing, and she will be in attendance at the event next Friday, that roundtable discussion. She is one of our partners on a lot of our Black maternal health issues. I don't know if you had a question more specifically about Homeland Heart, but if so, feel free to drop that in the chat and hopefully I can answer it. Yes, so that is a great question. Somebody said that they are a community-based doula and they expressed concern about people going through certifications with majority white programs, and if they'll have to go through other certifications to be a part of TennCare. So currently the bill as proposed or as introduced, and again, the language of the bill could change. It could maybe not even get signed into law at all. So I can't answer definitively how it will actually look in Tennessee moving forward. But currently as proposed, the Department of Health will be tasked with creating a certification process. So there are core competencies, and I can actually go back to that slide. There are core competencies that a doula would have to demonstrate. So 1 through 5 are all of the things that a doula would have to demonstrate they are knowledgeable of and capable of performing. Now, how the state actually verifies that a person is knowledgeable of those things and capable of doing those things is up to the Department of Health, the way that the bill is currently written. How the Department of Health is going to choose to certify people, I do not know. That it's completely up to them. We recommend against just greenlighting people who have certifications from from those large national and international doula collectives, just because we feel that that leaves community-based doulas behind. But that is one possibility for what the state could do. Thank you so much for your questions. If anyone else has questions, I will still be here. Sorry, I was muted. Someone asked, is there a new bill that's out that's trying to get doulas covered? Yes. So Senate Bill 1739, which is currently on your screen, is, yes, you are correct. So the bill last year, let me go back. So the bill last year, Senate Bill 0394, you are correct, as introduced, attempted to get doulas covered. But yes, it ended up just setting up an advisory committee. And Senate Bill 2150 just studied previous pilot programs. But Senate Bill 1739, which is on your screen now and is currently in the Senate, is attempting to actually get doulas covered by TennCare. All right, so this question or comment says, as a Black doula, I did advise the organization that I went through to add more books of color because all of the books they required me to read had nothing to do with women who look like me. They said they would and allowed me to substitute 2 of the 5 books with books that discuss women of color in our stories. That's I thank you for sharing that. And we actually have a QR code, and I will have this sent out in the follow-up as well to share your Black maternal health story. And so you as a Black doula, I think, have an invaluable insight, and just the way that you are advocating for reform in the curriculum to actually get doulas trained. So if you would be so kind to leave your story about how you advocated for that reform. I think that that's something that people need to see, and see why it's so important for there to be community-based doulas that understand the unique social context that their patients are living within. All right, someone asked, are they going to wait for the advisory board's finding? I'm confused as to why this bill is back on the table. Yes, so this is a great question. This is another reason why, in addition to the fiscal note that's attached to Senate Bill 1739, the advisory board is another reason why we're thinking that this bill may not get passed this session. The advisory committee is expected to make their recommendation in 2025. Again, this committee is recommending core competencies that a doula must meet, as well as a fee reimbursement schedule. We and other advocates are thinking that the state may wait until the advisory committee makes their recommendation to move forward, which is why we may explore other avenues of advocacy to get the ball rolling a little bit more quickly. All right, what can healthcare workers do to support this work? We want our patients to be able to access doulas and for doulas to be appropriately reimbursed for their time. I think that provider perspectives are so important. In Georgia, there was actually a doula pilot program, and they asked doulas about their experience. They asked patients who actually received doula care about their experience, but they also asked clinicians about the interactions with doulas. And I know that some doulas do not always have positive experiences with providers, that they don't always feel welcomed on providers' teams. So I think that that is one thing that you as a healthcare worker can do, is make sure that you are including the doula in your decision making, and that you are listening to the concerns that they are expressing, because at the end of the day, they are advocating for their patient. But I think that the other thing that you can do as a healthcare worker is to express that you are interested in doulas and you are excited about doulas, and that they are a welcome member of the birth team. Someone said this was before. Yes, so I said that I'm in the follow-up email after this event. So all of you all here, you registered, so we have all of your emails. And then the follow-up after this webinar, we're going to email out the registration links for those 2 events that I mentioned, as well as a Black maternal health survey. It's essentially a story collection survey. And so I was saying that you, as a Black doula, as somebody who, you know, has experience practicing as a doula, but also experience advocating for a diversified curriculum, you have an important story to share, and you can fill out that survey to leave your to share your story, and that will be sent to you after this webinar. But thank you for sending your email. I will reach out to you if we think that there would be good collaboration in the future. Is the advisory board diverse? So the advisory board of the doulas, there were 3 doulas on the advisory committee, 2 of whom are white, 1 of whom was Black. The Black doula has since stepped down from the advisory committee due to issues about whether or not we were actually satisfying the language that was in last year's bill, and whether or not she was an appropriate representative. So currently, the Doula Advisory Committee is a little bit at a standstill. All of those meetings, by the way, are public record. You, as a member of the public, can attend. I attend myself. The meeting minutes are made public, so you can review what was discussed at that meeting. So currently, my understanding is that there is not a doula of color on that advisory committee. They could have picked a replacement and I just not be aware of it, but the last that I checked, there is currently no doula of color on that advisory committee. All right, I see there are still a few more of you here. I will be here as well, so if you have more questions, feel free to leave them in the chat. All right. Well, thank you so much for joining. For the couple of you who are still on, we will send out the registration links for the events next week and the week after in a follow-up email, as well as that survey to share your story. We hope that you continue to follow TJC, and you can sign up on our training hub to access all of our previous and future trainings. Thank you so much.